Hello guys, my name is Kolade Ajayi. I'm going to be talking about the management of treatment-resistant depression with ketamine. We know about depression and we know the different medication that uh, are being used to treat them. The SSRIs, wellbutrin, tricyclic antidepressants, and they are a proportion, that is a fraction of that group of a population that don't respond to treatment. And that is the focus and the emphasis of this presentation. Uh, they are called the treatment-resistant depression. They are defined as depression that does not respond to treatment, to antidepressants. Rather, they are classified with if at least 2 subsequent treatment trials were recorded within the first year after the first antidepressant prescription failing, common among patients with major depressive disorder. Major depressive disorder increases the risk of developing substance use disorder. So that is a brief description of the problem and the description of the proposed practice change. The proposed practice change is the use of ketamine. Ketamine began its journey in 1956, discovered by chemists in Park Davis Company with fascinating and unique qualities of drunkenness as found in rodents, delirium in dogs, and delirium was also found in human, anesthetic effects in human as well. But what made this unsuitable for human use was the undesirable prolonged delirium state. So what they did was they redirected their effort towards synthesizing a shorter acting analog of the compound phencyclidine that will have the same or similar anesthetic potential but with less emergence of delirium. That was the birth of ketamine. It was approved in 1970 by FDA for human consumption. Route of administration: intramuscular, intravenous, oral, rectal, intrathecal. Bioavailability, which is the proportion of that enters the circulation in terms of IV, is 100%, IM 93%, intranasal 8 to 45%, PO 17 to 29%, rectal 11 to 25%. Pharmacokinetics, which is what movement of the drugs within the body. Distribution volume varies from 1.5 to 3.2. Clearance in the range of 12 to 28 mils per kilogram per minute. Absorption: rapidly absorbed through intramuscular, nasal, and oral route. First pass metabolism in the liver. Distribution: high lipid solubility and low plasma protein binding, facilitates rapid transfer across the blood-brain barrier. Initially distributed to highly perfused tissues, including the brain, to achieve level 4 to 5 times dose in plasma. Central nervous system effects subside following redistribution to less well perfused tissue. And distribution half-life about 2.7 minutes. Biotransformation elimination primarily takes place in the liver. Pharmacokinetics: interaction metabolized by enzymes from the cytochrome P450 family. Pharmacodynamics, which is what the drugs do or ketamine does to the body. It's rapid-acting general anesthetic producing an anesthetic state characterized by profound analgesia, normal pharyngeal, laryngeal reflexes. It has normal or slightly enhanced skeletal muscle tone. It has cardiovascular and respiratory stimulation. Occasionally, a transient and minimal respiratory depression. Ketamine is a dissociative anesthetic. It enhances descending inhibitory serotonergic pathway and can exert antidepressive effects, which is the focus of our presentation. Uses anti-inflammation, antidepressive, and anti-suicidal effects, chronic pain management, acute pain management, anesthesia in the operating room. So we've talked about the brief description of the problem. We've talked about a brief description of the proposed practice change. Then we're going to be talking about the presentation of evidence. We are going to introduce this. How are we sure that it's going to work? Well, we're going to present evidence to buttress this point. So evidence one found was rapid relief of treatment-resistant depression by facilitated ketamine infusion was conducted by Devor Best 2014. What they did was they reviewed the efficacy of combining transcranial magnetic stimulation (TMS) and ketamine infusion in 28 patients with varying degrees of treatment-unresponsive depression. Some received both, some received either, and the rest received none. And the result was amazing. It shows that those who fully participated in ketamine and TMS combination experienced relief of their psychiatric symptoms in the first month, which shows the synergistic effects of the combination of TMS and ketamine. Evidence 2. Ketamine infusion for treatment-resistant depression by Diamond and others. What the authors tried to do was to determine the effect of cognitive function of multiple ketamine and concurrent antidepressant medication, comparing the response rates and duration. So this is similar to the previous one in the use of ketamine and TMS. This one, use of ketamine and antidepressant. And the result shows that the patient on ketamine that continued their concurrent antidepressant showed better response time. Evidence 3. Randomized control trial literature review, which was done by Grady, Marsh, Tenhouse, and Klein on the treatment of major depressive disorder and bipolar depression. The result shows that ketamine demonstrated a statistically significant over placebo or midazolam in major depressive disorder management, and it was thus concluded that ketamine is very helpful in reducing symptoms in patients treated with resistant depression and bipolar. Evidence 4 was a retrospective study to examine the safety and efficacy of oral ketamine therapy in an outpatient setting by Atzberg, Garrett, de Gionis, and this was done by reviewing the hospital records of patients who received oral ketamine treatments, comparing the number and duration of psychiatric hospital admissions before and after treatment. They found out that the inpatient hospital days were reduced by 70%, hospital admission reduced by 65%, and the required dose required by patient was stable over time with neither tolerance to medication nor long-term negative effects. Evidence 5. It was a single infusion of ketamine improving the depression score in patients with anxious bipolar depression by Ionescu, Lockenbaugh, Nikhil, Richard, and Zarat in 2015. They achieved this by trying to determine whether baseline anxiety status reduced ketamine ability to decrease symptoms of depression. 36 patients in total were used for this, 21 anxious. 15 non-anxious and depression rating scale were used in post-hoc analysis in anxious versus non-anxious depressed patients through 14 days post-infusion. And the result shows that both anxious and non-anxious group had antidepressant response to ketamine, which was another very significant research evidence. Evidence 6 was a systemic review of the role of ketamine in treatment-resistant depression by Serafini, Holland, Rovedi, Girardi, and Amore in 2014. The research focused on the main pharmacological properties and impact of ketamine in treatment-resistant depression. And they use literatures such as PubMed, ScienceRx, and Medline databases. And the finding was astounding. It shows that most studies demonstrated that ketamine has a rapid antidepressant effect in treatment-resistant depression. So I haven't talked about these various evidences. What are the recommendations by researchers for potential implementation? So the recommendations are as follow. There should be like a supervising clinician, a physician experienced with ketamine. Administering clinician should also be on board, which could be a registered nurse, physician assistant, a nurse practitioner who has completed formal training in safe administration of moderate sedation. Also, individual with suspected or at high risk of cardiovascular disease, there should be like a baseline EKG testing just to kind of rule out the fact that they will poorly tolerate the infusion, and also to have a baseline EKG just in case of any changes. ST widening, QR widening, ST elongation, and all that. The setting dosages shouldn't exceed 1 milligram per kilogram per hour. Monitored setting containing resuscitative equipment and immediate access to rescue medication and personnel who can treat emergencies. And although this dose may vary based on individual characteristics. And monitoring should also be done. There should be vitals, blood pressure, pulse, the breathing, and O2 saturation should be checked, and I should be prepared to intubate when administering ketamine. Relative contraindication to ketamine that is of note that should be noted. Poorly controlled cardiovascular disease, pregnancy, active psychosis, those are contraindication, meaning that they should not even consider it. Severe hepatic disease, moderate hepatic disease should caution. Elevated intracranial pressure, elevated intraocular pressure, active substance abuse. Implications for practice. Implication for practice, ketamine will phase out. This is a prediction that ketamine will phase out the years of trials and errors of various medication usage in patients suffering from treatment-resistant depression. All those years of trial and error, try this, try that, will phase out with the introduction of ketamine. It gives hope for suffering, reducing treatment time and cost. It will also improve the life of 1/3 of the patient that do not respond to traditional form of treatment. Presently administered in office, future research would likely come up with appropriate dosage for home usage. Last but not the least, as it gains popularity in usage for depression, it will also gain admiration as being used as street drugs. Yeah, we are also confident that there will be research that will be done in terms of policy to curtail uh, and prevent addiction. That is all uh, that I have. Thank you for listening. Have a wonderful rest of the day. Bye.